say that I am very new to all of this, and if you have any ideas or anything you want to see me do, I am always open to these kinds of things in the comment section. So drop whatever you like, and who knows, I might just do it. So today I am still studying for boards. I worked all day, and as you can probably tell, it's night because there's a shadow over there. But sometimes I have to study at night, so here we are. Today I am going to shift slightly away from cardiology and talk about general internal medicine. I hope you either learn something or, yeah, I bore you so much you just pass right out. So, one or the other. I'm okay with either one. Let's jump in. Alright, what do we got here? It's an older lady, 80s. Shortness of breath when she walks around. She's got COPD. Was hospitalized about 1.5 years ago for it. Not worsening symptoms, which is peculiar because she's here for kind of the same thing, but I digress. She's got a little bit of a cough, stopped smoking a bunch of years ago, 15 actually, that's important. Substantial impediment to quality of life. She has heart failure with a perturbed ejection fraction. I have no idea what the medication is. I've never seen that in my life. That's probably a red herring. Vital signs are good. O2 sat is actually higher than it should be. If she's got COPD, it should be between 88 and 92%. This lady's is apparently 96%. And I don't know if I was clear the last time. These are like fake patients. None of these are real. So I just want to be clear. Let's see. She walks around and it's still 96%. Okay. Prolonged expiratory phase, intermittent scattered bronchi throughout her lung fields, and hyperresonance to percussion. We already know she has COPD. That sounds like COPD. Cardiac exam, Rios, and S4. Nothing else. Her FEV1 is 42% of predicted. What should we do for this poor lady? Well, that's a good question. The answers are furosemide, increase her oxygen, give her prednisone, or give her pulmonary rehab. This is a tough one. I don't think it's give her furosemide because that makes her pee, and she doesn't seem like she's volume overload because she's got no JVD, which says she's not overloaded. Increasing her oxygen is actually not what we want to do. Like I said, COPD, 88 to 92% is the sweet spot. If she's at 96, she probably doesn't need that 1 liter of oxygen. The question is, do we give her prednisone or pulmonary rehab? I don't think she's in exacerbation. She is not experienced acute worsening of her symptoms, meaning it's been a stepwise kind of a thing, which makes me think prednisone is not going to help it. So I'm going to say pulmonary rehab because I think she just needs to get her lungs stronger. She needs like actual rehab. Swish. 79% of people said that, so I'm not special, I promise. Alright, let's see. So we got a 50-year-old guy going in for a shoulder surgery. He's got alcoholic cirrhosis and osteoarthritis. Yikes. Lactulose, Lasix, Aldactone are his medications. He stopped drinking about 5 months ago. Has difficulty with medication adherence. Good for him. Well, for stopping drinking 5 months ago, not for his difficulty with medication adherence. Increasing ascites, lower extremity edema. Okay, fair. Vitals are normal. No jaundice or sclerolectrus. Jaundice means you're turning yellow, and sclerolectrus means I'd say your eyes are turning yellow. Spider telangiectasias on the face and chest. Okay. Distended flank. Dullness. Okay. It's got a little bit of edema. MELD score is 22. Patient is instructed to increase his furosemide as diuretic. Makes him pee more, gets rid of the ascites, which is essentially belly fluid. What do you do next? Cancel surgery, refer for liver transplant eval. Delay surgery until he achieves 1 year of sobriety. delay surgery until after replacement of a tips, or surgerize him. I don't have a good feeling about this, and I haven't clicked the button yet. I just selected my answer. Referral for a liver transplant eval. He's not been sober enough to qualify, so that's wrong. Delay surgery for a year. Until he gets a year of sobriety. I don't know that that's correct. Give him a tips. Or surgerize him. I think you just surgerize him. I don't think you actually need to do anything. Interesting. They want to send him to a liver transplant eval. Well, wrong again, Mike. Patients with cirrhosis but no complications are referred to as having compensated cirrhosis. Interesting. He has ascites, so that is a complication of cirrhosis. So you send them to transplant center if their MELD score is greater than 15. MELD, MELD, model for end-stage liver disease, model end liver disease, MELD. Anything higher than 20 is at a high risk for death. Awkward. Alrighty. The deciding factor in this case is not the patient's duration of sobriety. Okay, so because his disease is so bad, that's why you send him for a transplant. Fair enough. Okay, I learned something today. It don't always happen when I do these questions, but sometimes you get lucky, learn stuff. Okay, let's see. I think this is going to be a statistics question. That's going to be really awkward to describe on Mr. Camera. Mr. Camera. There we go. Now I'm focused again. Let's see. I don't know what that means. I read the top little blurb. That actually doesn't have anything to do with the question, but let's see what the question is. 24-year-old person is an add-on for a patient for 1 week history of nasal congestion, watery eyes, and cough with productive yellow sputum. New to the practice, indicated on the intake that his gender is trans male. He responds to questioning that he would prefer to be addressed as he or him, but he seems nervous. No feverish chills about the rash, takes no meds. Physical exam, vitals are fine. He's got some swelling in his nose. He's got some snot coming out. Nothing else really. Everything else is clear. Next step in management at this visit. A lot of the questions are, do you do anything about the transgendered situation that he's got going on? And no, he came in for a nose thing, so you just do his nose thing. So I believe the correct answer here is symptomatic treatment. I'm not going to perform a general exam or ask him about STIs or a social and sexual history or hormonal and surgical history. No, I'm not going to do any of that. I'm just going to treat the symptoms. Yeah, I mean, frankly, I don't care that he says he's a trans male. Like, great. Doesn't impact how I treat this patient. So, there are certain situations where, that's pertinent information, somebody who's transitioned from, female to male while identifying as male and he, him pronouns and all that good stuff. If you weren't born with a prostate, you can't get prostate cancer, but if you were born with a cervix, you could get cervical cancer. Those sorts of things are pertinent, but doesn't matter. Let's move on. they know his meds, I guess. The husband and wife. Discharge summaries given. Follow-up appointment is scheduled in 7 days. Which of the following is also recommended to improve the patient's safety and reduce rehospitalization in this patient? Let's see. Follow-up telephone call and 1 home nursing visitation. Home telemonitoring, post-discharge patient education. Timely discharge summary for the patient, or the primary care physician. I think follow-up telephone call just to make sure how he's doing and have the nurse go there. If this is a heart failure patient, there are some very classic things that you see in heart failure patients. There's things like leg swelling, for example, or you might have fluid in your abdomen. It may collect there, it may collect in your lungs, and then all of a sudden you have crackly lungs when you listen to the stethoscope. So I think somebody visualizing and laying hands on this patient will catch things early before they become emergencies. I believe the answer is follow-up telephone call and a nursing visit. Interesting. Most people agreed with me, but apparently that's not the correct answer. The question is, it's a timely discharge summary for the primary care physician. I'm not going to read the response here, or the explanation, but if they're making the argument that 7 days is close enough to discharge without needing anything from the hospital or cardiologist's office or the nursing service, maybe. Let's see. Interesting. 1 telephone call within 7 days of discharge and 1 nurse visit at home within 10 days of discharge found no difference in all-cause mortality or readmissions. Interesting. I would not have guessed. Alright, so get it done. Go see your PCP. Let's continue. 54-year-old guy. 6 months shoulder pain. Moderate to severe. Doesn't go down to the arm. Constant, worse at night and with movement. Insidious onset, progressively worsening. No neurologic symptoms, no constitutional or B symptoms. Ibuprofen kind of works. Pain and limited range of motion are noticed with both active and passive movements in all planes of motion. Difference between active and passive. If I move my shoulder, this is active movement. If I relax my shoulder and somebody moves it for me, that's passive movement. Diffuse tenderness over the anterior and posterior areas of the right shoulder, front and back. Nothing tender to palpation or pressing of the bony or soft tissue structures. Nothing in the cervical spine. There are no neck symptoms or findings. What is going on? Acromioclavicular joint degeneration. The AC joint. It's there-ish. Adhesive capsulitis. Bicipital tendinitis. Rotator cuff disease. Now, there is limited range of motion with both active and passive movements. If there was limited range of motion with only active but not passive movements, that could be AC joint degeneration, it could be tendinitis, it could be rotator cuff disease. But it's with passive. If somebody moves my arm and can't get it past here, that's stuck. That seems like adhesive or stuck capsulitis. Let's see how I did. Yep. Moving on. Some of these are like, I know them. And I don't know the question, but I know exactly what the condition is. And I don't want to spend more time on them. 32-year-old guy. Sounds familiar. Intermittent premature ejaculations for 3 years duration. Oh god. Yes, distressing to him and his spouse, I can imagine. No other symptoms. Depression with controlled amitriptyline. Not my first choice for antidepressants. Sertraline didn't work. Creatine, testosterone gel, topical lidocaine. His testosterone is normal. Lidocaine, I don't know what you're doing with lidocaine. You. Apparently, you give him lidocaine. Yeah, I mean, it's distressing him and his wife, so you gotta do something apparently. And lidocaine to, I guess, numb him. Okay, sure, I'll take your word for it. I learned something else new today. Alright. 60-something-year-old lady, urinary incontinence. It's worse over the past 2 years. Laughing or sneezing. But nothing else. Postman's impossible. 4 kids. No other problems. BMI is normal. Vaginal atrophy, remainder of the exam is normal. What is the most appropriate treatment? Well, vaginal atrophy means there's, bladder training, oral estradiol, which is just estrogen, oxybutynin, pelvic floor muscle training, like Kegel exercises, and weight loss. Yeah, it's Kegel exercises. This woman has had 4 births. Like, good for her. That's a lot. I will say that some people said bladder training. I don't know what that means. She needs to strengthen her pelvic floor muscles to keep the urine in. It's a very common thing for women over this age of 60 with multiple vaginal births. It's very common, and it's something that, we frankly expect. I think there's a stigma among women of that age that says, oh my god, my body's falling apart. It's like, no, you can blame your kids for this. It's okay. 80-year-old lady, 8 days in the ICU. All of her organs are failing because she had a really bad pneumonia. She's on the ventilator. They can't wean her from the ventilator. She is unresponsive to verbal stimuli. She has dementia, diabetes, COPD, kidney disease, heart failure. Care team says with the patient's family that she will not have a meaningful recovery, but the patient's children request continued ICU level care. The patient does not have an advance directive, and her wishes are unknown. After a family meeting with the care team to discuss the patient's prognosis, the children continue to request all treatment. Which of the following is the most appropriate management? You continue the care. Apparently not. You talk with the hospital ethics committee, which is something that I've never had to do. What they're trying to get to, this woman will... Okay, so she actually won't get better. That's what they're arguing. Okay, fine. Okay, 50-year-old lady. Nothing's bad all today. Okay, so we have a 60-year-old lady with chronic pancreatitis. That hurts a lot. Her only surgical option is a pancreaticojejunostomy. Pancreaticojejunostomy. Say that 5 times fast. I will not. Likely because I cannot. She's tried what looks like everything. Well, she got a fentanyl patch and some morphine and then got better, as you might imagine. Her only medications are fentanyl, and prednisone and pancreatic enzyme replacement. She is frail appearing with a normal BMI. The abdomen is scaphoid. Ooh. Means it's like concave. She's still tender. Most appropriate next step in management. Add lorazepam, which is a benzodiazepine. Prescribe naloxone and provide the caregiver education on its use. Recommend weekly nursing visits before each opioid prescription. Switch the fentanyl patch to short-acting hydromorphone. So she got better on the fentanyl, and I think she needs naloxone, because if you overdose on an opioid, that'll kill you. And naloxone or naltrexone, or Narcan as it's known, can save your life. It looks like there are some questions in this question bank that are now, for lack of a better term, old, perhaps. So it says, hey, click A and you'll get the question right, and you're not going to be tested on it. So I'm going to do that. Okay, 65-year-old guy. He's salvaging care, wants colon cancer screenings, but he does not want to undergo colon prep. And he does not want to modify his diet for screening. Okay. Fun. Everything's normal. He does not want to do that. So how do you screen him for, essentially, how do you screen him for colon cancer if he doesn't want a colonoscopy? Circulating methylated sept9 DNA test. CT colonography. Fecal immunochemical test. Sensitive guaiac-based fecal occult blood test. The fecal immunochemical test is correct. It's essentially like Cologuard. We very rarely use the guaiac tests for anything these days. I don't like them. I still refuse to use them. But I digress. 35-year-old lady has anxiety. Well-controlled symptoms with cognitive behavioral therapy. Good. Been drinking kava tea every morning. I don't know what that is. And practicing mindfulness daily. Great. Big fan. Non-alcoholic steatohepatitis. So she's got fatty liver. She takes folic acid and echinacea. She is obese. Her BMI is 36. Everything else is fine. What do you do for this patient? I don't know. I have no idea what kava tea is. I would say we have no idea what kava tea is and maybe stop it. But I don't know what kava tea is. I would probably say if I saw this woman in my outpatient facility, I was like, you know what? I don't know what kava tea is. I don't know if this is making your liver bad, or it's making you feel better. I'm not sure what it's doing. Why don't we stop it? I'll research it, and I'll call you. That's probably what I would say. But I have no idea if that's the right answer. But that's what I'm going to go with, because that's what I'd probably do. Hey, I got it right. Good for me. Let's see if it talks about echinacea at all. Oh, well, kava is actually associated with liver damage, so there's that. Echinacea might be slightly effective for prevention, but not treatment of the common cold. Okay. I'm not sure how. I wish I did, but I do not. So here we've got a 70-year-old guy who's going to have spinal cord surgery. Well, spine surgery, not cord, just the spine. Coronary artery disease. Okay. He swims for 30 minutes every other day. Good for him. No chest pain activity. is on good medications for his disease. He has a left anterior fascicular block and several premature atrial contractions on EKG, but otherwise sinus rhythm. What do you do for this patient? Oh, so that EKG was 2 years ago. You're going to need a repeat EKG for this guy. The answers are stress echo, EKG, exercise stress test, or nothing. You're going to get an EKG. You're going to get an EKG. 48% of people said no further testing. That is wrong. I wonder if they just missed the 2 years ago thing and forgot it was 6 months ago that you needed. I think it's probably going to be fine in this guy, given that he swims for half an hour every other day. I can't do that. That is way more than you need to be able to do to undergo surgery. Like, way. Alright, let's do a couple more real quick here. 45-year-old guy hurt his elbow 2 months ago. It's getting worse. Worse when he bends his elbow and his right, fourth, and fifth fingers are numb. I hate when that happens. Vitals are normal. Decrease sensation on those fingers. Weakness of those fingers. Right elbow has full range of motion. What does he have? Carpal tunnel, medial epicondylitis, olecranon bursitis, ulnar nerve entrapment. Well, these two fingers, these two right here, boop, boop, they're controlled by your ulnar nerve, because on the inside, if you look at your forearm, here, we can look at this forearm. This is where it hurts. This is where your ulnar nerve goes, right up through here. And how conveniently I'm pointing now at my fourth and fifth fingers. I'm pretty sure he's got ulnar nerve entrapment because he has weakness and loss of sensation. Yeah, everyone almost got that one right. 65-year-old lady passed out, nobody saw it. She felt warm and weakness prior to the event, but no chest pain, dyspnea, which is shortness of breath or palpitations. She has, classic 65-year-old lady problems. What should you do to evaluate this patient? Should you get an EKG and an echo? Should you get a BNP and cardiac enzyme measurement? Should you get a magnetic resonance, carotid angiography, and brain MRI or orthostatic blood pressure measurements and electrocardiography? This is interesting. The initial evaluation should probably include orthostatic blood pressure and an EKG because that's easy to get. It's more difficult to get an echo. I think that's what I'm going to go with that one. Yeah, that's right. Sometimes these questions aren't like, what do you want in an ideal world? It's, what are you going to do first? You're always going to do the simpler things first in the outpatient setting. Throw an EKG, take blood pressures with, laying flat, sitting, standing. Very easy to do, very quick. You're going to do those first. And then maybe you send her for that echo. Okay. 43-year-old lady, following up for obesity. Reduced calorie, low-fat diet, 45 minutes of aerobic exercise 3 times a week for the past 6 months. Good for her. Last follow-up appointment was a month ago. She added 30 minutes of brisk walking on the weekend to her exercise regimen. Great. Brings a food diary, weekly weights. Great. Losing half a pound a week over the first 3 or 4 weeks. But she has lost only 1 pound since her last visit. Over 8 months, she has lost 6 pounds. Unable to achieve the calorie reduction recommended. She is hungry all the time. She has type 2 diabetes and high blood pressure. She is on amlodipine less than her limit metformin. Blood pressure is a little high. BMI is 31. Next 7 treatment. Bariatric surgery. Liraglutide. Switch to a low carbohydrate diet. Switch to a very low calorie diet. very low calorie diets are worth it, really. One, it's not a really good quality of life, and I don't believe in them. Two, the bigger you are, the more food you actually need to maintain your body weight. For example, if you're 400 pounds, you need a lot more food than somebody who's 150 just to maintain your body weight. That's how it works. Bariatric surgery in a woman with a BMI of 31 is probably not indicated. Now the question is liraglutide or a low-carb diet. It doesn't say what her A1C is, but she has type 2 diabetes. I wonder if switching to a low-carb diet might be a good idea for her. Or they're trying to test me and tell me that liraglutide helps you lose weight. I don't like this question because I don't know how much metformin she's on. And I don't know what her A1C is. Yeah, they were trying to tell me liraglutide. Oh well, fine. There is no evidence that low-carb diets are more effective in reducing weight than low-fat diets. They're all just kind of tricking you into eating fewer calories, to be honest with you. Same thing with all fat diets. Keto, South Beach, whatever it is you want to do. They're all trying to trick you into consuming less. That's how it works. Don't let anybody sell you any fit teas, or I call them diarrhea tea because they just give you diarrhea. That being said, fewer calories. She's having a hard time with the fewer calorie thing. I get it. Been there. Liraglutide has been shown to increase satiety. Interesting. Well, liraglutide it is. I learned 3 things today. Good for me. 37-year-old guy inquires about a palliative medicine referral. After he got sent home from the hospital, he has metastatic non-small cell lung cancer. Bummer. He got a thora with 1.5 liters of fluid out. And a substantial relief of his shortness of breath, as you might imagine. Medical oncologists plan to initiate disease-directed treatment soon. Medications are steroids, pain control, and help to poop. When is the appropriate time for a palliative medicine referral? As soon as humanly possible. Absolutely, palliative care physicians and the PAs and the NPs that work there are absolute saints, and they work wonders for patients and their families. Now is the correct answer. Yeah, it's the correct answer. I love our palliative care team. They're fantastic, and they do so much good for so many people. I cannot talk them up enough. Okay, last one. 37-year-old lady has 6 years of difficulty getting to sleep and significant daytime sleepiness. She's a nurse. Her daytime sleepiness is exacerbated when she works several night shifts in a row, as you might imagine. No tobacco, no alcohol, no caffeine. How she works as an overnight nurse with no caffeine, I have no idea. How? I would like to know how. Yes, very much I would like to know how. New exercise program, 3 to 4 morning each week. Great. Normal vital signs, B minus 30. Everything else is fine. What is the most appropriate next step in management? I mean, I don't know that there's anything like physically wrong going on just yet. I want to know what she's doing before she goes to sleep. I would imagine she's 37, and yeah, it gets worse when she does night shifts, so this is related to her sleep-wake cycle. I think taking a 2-week sleep diary is the correct answer. Some of the other answers are sleep latency testing, overnight oximetry, polysomnography, or ferritin level measurement. Sleep latency testing is essentially if you go to bed, you stay up for a bunch of hours and you can't fall asleep and you don't know why. It's been 6 years of difficulty initiating sleep, though. That's a long time. Has she been a nurse for 6 years? Yeah, probably. She would be 31. Yeah, I think it's a sleep diary. You know, I don't know. This is a question I don't know the answer to. Yeah, it's a sleep diary. 20% of people said polysomnography, which is the test you have to diagnose sleep apnea, or to be suggestive of sleep apnea. She doesn't scream sleep apnea. You know, people with sleep apnea tend not to have issues falling asleep. They wake up many times over the night because when they go apneic, essentially you stop breathing. That usually wakes you up. She needs a sleep diary, I think, just because there might be stuff around her that maybe she's not picking up on that's keeping her awake. Like the phone, or the TV, or the dog, or the neighbors, or the traffic outside that you can probably hear right now. I think, yeah, sleep diary. I'm glad I got that one wrong. And I'm glad I got to end on a positive note. I got a lot of these questions wrong. I shouldn't say a lot, not that many, but that's what studying's for. So if you are studying, or you're using this to help you study, remember, an incorrect question is not a failure. It is an opportunity to make yourself better. Treat it that way. That being said, it is always nice to get the questions right.